Got it? Slow down. That's all right. All right, got it now? So those are your potential answers. How many people think E? How many people think A or D? How many people think C? Couple. B and A. History of popping and clicking, right? You haven't done the rest of the exam, so you don't know everything else. But that history of popping and clicking, he had pretty good motion, so his rotator cuff is probably functioning pretty well. He had a little pain with external rotation, so there was a limited component. So that's how you take that history and start to think what's going on. So rotator cuff tendinopathy would have been the second most likely choice behind that, but it's definitely not frozen shoulder, too much motion. And they could lift their arm all the way up almost, so their cuff is probably intact. Does that make sense? One more question. This one I could get the answers on. I like people trying to move and do the test. Knows your brain is thinking. It's okay to move. All right, what's the answer? Perfect. Well done. So I'm going to integrate some clinical scenarios, but I'm also going to ask you some rote knowledge. Okay? I'll try to do more clinical scenarios or how you would organize your test. What's a positive apprehension test or something like that? That's more rote memory versus a scenario like I gave you. Cool? Does that help? Good question, Kristen. You probably won't see these two questions. Inadvertently, maybe. Okay, I set my clock up here for a 1 hour break, but I got a lot to go through, so I'm going to rock and roll. Y'all are used to me moving pretty fast, right? So elbows are basically going to do one of two things. They're going to push you away or pull stuff towards you. Those are the big functional aspects. So of those two motions, pulling stuff towards you, feed your face, wash your mouth, wash your face, are probably more important than pushing away, depending on your job and those activities. But we all need to eat. We all need to brush our teeth. We all need to wash our face, comb our hair if we have any. Okay? So those are the basic functional components. One of the biggest complications with elbows is all the nerves that cross that. So 3 of the 5 main upper extremity nerves, median, radial, ulnar, all cross the elbow joint. All can be potentially involved. So that's one of the challenges when you go through that. So I've taken a little bit of a different approach. I spent all weekend remodifying this, tried to give you a little anatomy overview, and then basically tried to break the examination, not how I would do it, but sort of by tissue pathologies. How I would do it is if they have medial elbow pain, I'm going to rule out medial problems. If they have lateral elbow pain, I'm going to rule out lateral elbow problems. Anterior and posterior sort of go together with that. Those are usually more traumatic mechanisms. But hopefully this will make it easier for you to understand and follow and digest. Is that cool? Those are the main tissues, right, in the elbow that you're going to be dealing with. There's one joint at the elbow, but there's one capsule, but 3 joints. So the radius, the ulna, the radial ulnar, the humeral radial, and the humeral ulnar. So you've got 3 articulations that all can get stiff, all can be damaged, but they're all sort of covered together into one joint capsule. Radial ulnar motion, pronation and supination, is directly linked with the wrist. So you can have a wrist pathology of something going on from a wrist injury, so you have to clear the distal radial ulnar joint if you have limited pronation and supination as you go through that. Just a quick review of anatomy when we get into palpation in lab. Those bony prominences like the olecranon, the medial and lateral epicondyles, you're not going to actually palpate the capitulum or trochlea, but just appreciate that. The head of the humerus, the distal end of the humerus is tilted a little anteriorly. It's got a little bit of a valgus orientation. So if you put your elbows out to your side, you have a little carrying valgus. You all learned that in functional anatomy. It goes away as you flex your elbows. As you flex your elbows, they become more in line straight with those activities. The proximal radius and ulna, again, we talked about the olecranon. You can sort of palpate the coronoid. You really can't palpate the biceps tuberosity, but those are all key sites of location that you want to try to palpate. What attaches to the radial tuberosity or bicipital tuberosity? Biceps, yeah. Not a trick question. So that's important for supination, right? The biceps actually helps to supinate that. You can palpate the lateral aspect of the radial head where the annular ligament is and the lateral complex of ligaments. So those are certainly important. This is all covered with articular cartilage. So what can happen with articular cartilage? It can go away, degenerative changes, or you can get joint mice. What's joint mice? You ever heard that term? It's a layman's term. Osteochondritis dissecans. So joint mice is what people say, oh, it catches sometimes, or it clicks, or I feel funny noises. So wearing away of that articular cartilage. It's like chondromalacia in the elbow. You all know what chondromalacia is, right? It's a softening of the articular cartilage. Yes, no, never heard that word. In pathomechanics, osteoarthritis, you all haven't talked about patellofemoral. So it's just the articular cartilage getting worn out. Doesn't happen in too many of you guys unless you're really heavy-duty laborers or have been doing a lot of farm work, or lifting and carrying and toting, or a lot of bodybuilding and weightlifting. This is the variation of the articular cartilages, but classically, the majority of the people sort of have 2 main surfaces on the coronoid side and olecranon side. It's not always a continuous component. Notice that this is angled a little bit posteriorly, so that matches with that anterior orientation. So the head of the the distal end of the humerus is tilted anteriorly. This is the ulna is tilted a little posteriorly. There's a little varus valgus that can be played with, a little bit of motion. So you can do varus and valgus stress, which we'll talk about in ligamentous testing. The elbow is very congruent, so when it's locked out straight, it's very stable because of the bones. If it's bent, there's a little bit of room of play. So if you get instability when it's locked out straight, you worry about something going on with the fracture. So the coronoid, really important. If that gets knocked off from an elbow dislocation, as you go to contract your biceps, it can slide the olecranon and the radius posteriorly. So it's an important component. That little C-shaped, that little tip in the anterior aspect is really important for anterior instability of the elbow, so you don't get a posterior dislocation. You typically get a posterior dislocation when somebody falls on an outstretched arm or hyperextends their elbow and they dislocate that. I talked already about carrying angles. It varies a little between men and women, but it's around 10 or 15 degrees. It appears to go away when you flex up. That's that little bit of varus and valgus. And if the person is standing in pronation, it's not going to be as obvious. So you have to have them stand or assume an anatomical position to really see that. So the first joint, the main elbow single flexion, is the humeral ulnar joint. It sits in that little groove. It's a little off-centered. So the axis of rotation is between the medial and lateral epicondyle, but it sits at a little valgus orientation. So when you do your joint mobs, or you do your joint mobilization, you got to keep the articular surfaces in mind that it might not be straight back, but it's actually at a little bit of a variation. Have you all learned concave, convex? Okay. So what do we have here? We have a big concave surface on a big convex. That looks concave also, but in relationship to that, this is basically a concave surface moving on a convex surface. So if you're restricted in elbow flexion, which way are you going to push them? Which way are you going to push the forearm? Posteriorly? So are you talking about that way or that way? To gain elbow flexion, it's going to have to move into elbow flexion. Does that make sense? Think about that. So I'm lost. I only got 90 degrees. I want to gain more flexion. I've got to move a convex on a concave. Okay? Or a concave on a convex, sorry. Is that, you with me there, David? Yep. Even though you pointed the other direction. What's that? Gotcha. So full elbow extension is the closed pack position. So the least amount of joint volume is there in full extension. The bone of the radius is a relatively flat surface. There's a little bit of concavity on that. This central area is called the foeva. This is a little thicker cortical bone on the rim, but it's not the strongest bone in the whole body, so it's common that you get a radial head fracture. This is, again, the bicipital tuberosity. That's where the biceps attaches. Notice that that's oriented a little bit anteriorly, so about 15 degrees. So at the neck, right here, it angles a little bit from the long axis of the radius. So the humeral radial joint is, again, a concave surface moving on a convex surface. So if you're limited in flexion, which way are you going to move it? Huh? Grace? Into flexion. Yeah, same direction. Good. Not a trick question, just making sure you keep it all straight. The radial head has this little outer rim. You all haven't really talked a ton about lower extremity, but it sort of functions a lot like a meniscus. So it provides a little increased depth and stability. So radial head is concave, gliding on a convex capitulum. So in extension, it's going to go posteriorly. There's no real stopping point, so you can do a little bit more posterior gliding. I tried to add this image so you could sort of appreciate that concave on a convex surface. In flexion, it will run into a little fossa eventually, especially if they don't have much of a bicep. So if somebody's not very muscular, whether they're sick or have relatively frail, something like that where you don't have that. Typically, flexion is limited by the bicep, so you have a soft tissue approximation. So the other motion at the elbow is pronation, supination. That's a pivot of the radial head. Again, it's attached distally, so you can't ignore that. So at the head of the radius, it spins on this little radial notch. It's linked distally. It, again, is only allowing sort of one motion, that pronation and supination in the transverse plane. The radius rotates on the ulna. The radius rotates on the ulna. So in anatomical position, the radius is a tad longer. In pronation, it's a tad shorter. Relatively shortens around that. Pronation and supination basically are going to go from the head of the ulna through the head of the radius. So it sort of crosses through the orientation of the forearm. Okay, so here you've got a convex moving radius on a concave ulna. So now you get to do the reverse like you were thinking about before. So the stability is from the annular ligament, and then if you're going to go from supination to pronation, it's going to roll anteriorly, so you're going to have to glide them posteriorly. That's the restriction, and that's the test you want to do as you go through that. So you're going to push on the radius and try to push it posteriorly to facilitate pronation as they go through that motion. Opposite for supination. Cool? Makes sense? So those are just the standard motion tests, passive overpressures that you want to do as you evaluate somebody's elbow. I just threw this up here real quick. This is sort of an end-on view. This is how we function. This is the radius. This is the ulna. So when you go to reach out and grab anything, most of the time your hand is in this position. So the radius sits on top of the ulna. We'll talk about the wrist later this week, but just to keep in your mind that functional position is sort of in that mid-range, and you get a lot of injuries and compression at this distal radial ulnar joint. Just wanted to make sure you all kept that in mind. When you're mobilizing distally, you have a concave moving on a convex surface. So you actually mobilize in the position or in the motion of restriction. Make sense? Okay, so I mentioned this earlier. This x-ray really shows it nicely. You can see there's sort of this like double S shape between the radial head and the anterior aspect of the ulna. The coronoid would be anterior. This is the olecranon fossa. But the stability at the elbow is very different than at the shoulder. We're very mobile at the shoulder. We're very stable at the elbow. So the bony congruency makes up a lot of stability. When you're flexed, the capsular ligaments help contribute, but in full extension, it's primarily bony. The muscles aren't oriented very well to provide a lot of dynamic stability. You get some support, but this is really much like the knee, where if a ligament is gone, the muscles can't always compensate for it. If it's partially torn ligaments, maybe you'll be able to get away with it if your job demand isn't too high. So let's talk a little bit about the ligaments. Has anybody ever heard of a Tommy John procedure? Anybody ever had one? Anybody treated one? Okay, so that's the baseball injury. So the Tommy John procedure is really rampant right now in youth baseball. All these kids are out throwing hundreds and hundreds and thousands of throws, and they start to wear out and damage their ligament. So we basically have radial or lateral side ligaments and then medial side ligaments. And so this illustration sort of identifies what's going on laterally, what's going on medially. So this is the medial ulnar collateral ligaments, and then the lateral radial collateral ligaments is what most people describe it. There is a lateral ulnar collateral ligament, so it's most appropriate to describe it as medial or lateral ulnar collateral ligament. And then the annular ligament also supports out here laterally. So this is valgus force. So not with the elbow perfectly straight, but a little bit of flexion. There's three primary parts of the medial ulnar collateral ligament. This is the anterior bundle. This is what gets torn in baseball players. High school, college age, pros, that they have to repair for the Tommy John procedure. It's primarily going to help when the elbow is in near full extension, but not locked out. Near full extension, but not locked out. This is a factoid that I might ask about on a test. Right? Makes sense? The oblique connects the ulna to the ulna, so it really doesn't have much role. And then the posterior is going to be more taut in flexion. So when my elbow is more closer to 90 degrees, the posterior portion, or posterior bundle, of the medial ulnar collateral ligament. So this is all one big ligament, is the way it's described. On the lateral side, we have the radial collateral ligament. It goes from the radius to the distal humerus. It helps varus stress. So varus stress, I'm bringing my elbow in. My forearm, I should say, I'm bringing my forearm in. It also helps if you're getting your radius pulled away, so it helps resist distraction. The lateral ulnar collateral ligament attaches directly to the ulna, and it helps, again, to stop varus and what we call posterior lateral rotatory instability. So this is a little bit higher level thought process, but I want you to be aware of it. But you can actually dislocate your radius and ulna, and when that actually occurs, these two ligaments are disrupted. And that's often the beginning of an elbow dislocation. And then the annular ligament connects the radius and the ulna. So I'm going to show you a test that you can do for each of those as we go into the examination. So this is just a reminder of the ligaments and their role and their function in the shoulder joint. Cool? How's this pace? Boring? No? Yes? Maybe? Okay. So let's get you moving a little bit here. So let's think about muscles in relationship to nerve function. So everybody extend their right arm. What nerve? So what nerve branch? Radial. Good. What innervates the radial nerve branch? What root levels? All of them. So it doesn't really help you discriminate what root level something's coming from. Most people say C7 a lot of times, but they all contribute. All right? Elbow extension and wrist extension is also radial. Okay? Finger extension, radial. So as you're doing active range of motion of the elbow, flexion, extension, wrist flexion, wrist extension, you're also doing a sort of scan motor assessment. Okay? And the radial nerve separates, did you all learn this in anatomy, posterior interosseous nerve? So that's a common area of entrapment. And so that can present as lateral epicondylar pain or lateral elbow pain. So that's a differential diagnosis. Those are more finger extensors. So the index finger and the abductor digiti minimi. So these little motions, also your thumb. So whatever rock and roll sign this is or street sign this might be, I'm not sure, but is it? I love the posterior interosseous nerve in sign language. My posterior interosseous nerve is working. So that's true. Is that a true statement? I assume it is. Why would you not say that? Cool. Isn't there something like this in like Hawaiian? Oh, it's this way. Gotcha. That's sort of like spasticity of the nerve. Gotcha. So, elbow flexion is mainly musculocutaneous, C5, C6. But don't forget that little tricky brachioradialis helps with elbow flexion. Really good to help you separate if you have a radial nerve palsy because it's innervated by the radial nerve. Okay? Even though it's still C5, C6. But most of the motion, brachialis and bicep, is musculocutaneous. Wrist flexion, finger flexion is divided in half. These two fingers, mainly median. These two fingers, mainly ulnar. Okay? FCU, flexor carpi ulnaris, one of the most powerful muscles in your body, in your forearm, ulnar. Pronator teres, palmaris longus, flexor carpi radialis, more median nerve. Supination and pronation. Supination is going to be bicep, musculocutaneous, and radial, the supinator. Right? So some of you will feel more motion or more resistance if you put them out straight. Sometimes you'll get more supination and flexion. I typically test it out here. It seems like that's harder because the bicep is really lengthened. So if I'm really trying to test supinator, I want their bicep sort of at a disadvantage. If you're in mid-range and testing supination, that's almost always going to be a heavy biceps. So if it's torn and they can't do that, that's a good indication of that. Pronator teres, pronator quadratus are going to be median nerve, and then a substrate off the median is called the anterior interosseous. So that's all median nerve function for those. And again, that's much like the radial nerve. that it's a conglomerate of the nerve roots. So when you all are figuring this stuff out, you have to look for common themes or common strings among those tissues to help you differentiate if it's a branch or a cervical root as you go through those assessments. So I talked about all of these. You all know this from your anatomy. If you lay your hand across the common medial origin, your forefingers, your index is your pronator teres. And when you palpate and you do this in lab, don't do heavy resistance, do light resistance. You can actually feel it a little better. The next one is going to be FCR, so that's a radial deviator. You can do flexion, but you get a lot of overflow from FCU. Palmaris longus, opposition. So as you bring those together, you can often see that if you have it in your tendon. It doesn't opposition, but it sort of attaches in that palmar fascia. And then FCU is an ulnar deviator. Any and all of those can be inflamed from a medial epicondylitis or epicondylalacia, medial elbow pain. We talked about the triceps. You can most easily palpate the long and the lateral head. The medial head is really deep. The anconeus, you can usually palpate if you put your hand over on the lateral side and fully extend your elbow. You'll feel that little muscle pop, just that last terminal extension, you'll feel that. Some cadaver research has shown that sometimes that's continuous with the lateral tricep. It's not actually a separate muscle. If you look at somebody's forearm from the lateral aspect as you're palpating, I think it's important that you sort of appreciate from most superior or most proximal to most distal. So as you're anatomically evaluating these patients and palpating, you need to know what you're touching. So a little elbow flexion is going to be brachioradialis. Extensor carpi radialis longus is going to do a little radial deviation with extension. ECRL and ECRB really can't be separated in manual muscle testing. Typically, the ECRB is more commonly involved with lateral epicondylalacia or tennis elbow, but both are very symptomatic. As we go out here distally, the extensor digitorum, a little bit lower, extensor carpi ulnaris, and then the anconeus. Okay? All of those have very common attachments right there. So you got a lot of muscles that you're trying to differentiate and figure out what motion do I need to perform to evaluate that. So I gave you another image, just sometimes it helps. This is the deepest. This is the supinator. It's also going to be on that lateral epicondyle, but much more deep. Then overlying that's right at the tip of the lateral epicondyle is the ECRB. ECRL actually attaches a little bit off. So if they're having pain a little higher up on their humerus, but it still hurts with wrist extension, could be more of an ECRL problem. You don't treat those any different, but it's just where you might want to focus some of your massaging or soft tissue work. Extensor digitorum attaches between them, and then the extensor carpi ulnaris is, again, right next to the ECRB. So I just gave you those other anatomy pictures sort of in deep to superficial layers as you go through there. So pronators are pronator teres and quadratus. Supinators are going to be the biceps and the supinators. And this right here is where the posterior interosseous nerve is developed. It's deep to the supinator. And that's why it can get entrapped. So it presents as lateral elbow pain, but it's not as tender exquisitely on that tissue. It's a little bit lower, about 4 or 5 centimeters down from the lateral epicondyle. So supination activities, gripping and supination activities can impair that or irritate that nerve. Pronation, again, pronator teres, pronator quadratus, more symptoms because the median nerve pierces through this between the heads of the pronator teres. These other muscles help with pronation, but they're not primary movers of that. So I put this reference up. It's a good video if you want to watch all the different mechanics and motions. This Dr. Ibrahim is really nice, does a good job. And then Bony Biomechanics is just some additional reading if you're interested in that. How y'all doing? Good? A lot of yawning going up here with Braden. You need to get up, move around. Y'all been all together all day or just now? About sick of each other? No, just kidding. Good. It's nice to have everybody in one room. I like this, but it's tough for you guys from Hazard, I'm sure, to get here. Okay, so the next part is the examination, sort of summarizing how I would think about going through that examination. Obviously, you want to look above and below the elbow joint. I've already talked about how much wrist motion and function affects the elbow, so obviously that's important to look distally and proximally, as we've been emphasizing over and over again. History, location of the pain, the beauty of the elbow and the beauty of the wrist, not like the shoulder, is if you can poke on it, it's often where the pain is. So knowing your anatomy and poking and getting really comfortable with what's directly under where you're poking really is beneficial and helpful. Don't go right after it right away because that biases the rest of your examination, but learning good palpation is important. What makes it better? What makes it worse? What treatment have they already gotten? Have they had any radiographs or imaging? What's their medical? And this is really important for occupation. So as we get into the hand and the elbow, occupation really is important because it's going to depend how long you're going to have to rehab these guys as they go back to different demands of activities. A couple of things you want to look at when you just have them stand there in front of you. Do they have any abnormal orientation? These excessive varus or valgus indicates when they're children, if they had a fracture that wasn't well managed or wasn't well reduced. So that can indicate a supracondylar fracture. This is a torn biceps tendon, so it's called a Popeye sign. If it swelling, redness, what is that? What is that? Y'all seen this before, right? Bursitis. Perfect. Outstanding. What's the problem with, what's the number one worry about bursitis? Chuck, my man. No. Infection. The bursa is really superficial. So if they have a bug bite, they have a abrasion, because usually this is from a rubbing or irritation. If it starts to look at all infected, that's a bad sign. Really, really bad sign. I've treated a couple of pre-patella bursitises that got infected in wrestlers. Very, very painful, very uncomfortable. Resting posture, and then certainly functional movements of elbow flexion, elbow extension, pronation, and supination. So in the literature, we have normal range of motions. We also have functional range of motion. This joint gets stiffer than any other joint you're going to typically manage. So what they've actually identified is doing different tasks, like answering a telephone, putting a telephone up to your ear, not on speaker, lifting a glass to your mouth, other activities. It shows you the functional range of motion you need. So for elbow flexion that's normal, we like 140, 145, 150. Elbow hyperextension of 0 to 5 degrees. 10, 15, that's a little loose. That's a little hyper. But you can function between 30 and 130. So if a surgeon is managing this fracture, his goals are probably not necessarily full range of motion. And so you might have to be happy or satisfied. We always want a little bit more, but they can usually function. But if they present to you at 40 to 90, you got a ways to go. You got some work to do. Same thing with supination and pronation. Normal range of motion is about 85 degrees supination, 75 degrees pronation, but you can live with 50-50. You can live with 50-50. Not ideal, not great. They did the same functional task. Okay? This is just in there for your edification, information on range of motion, typical values that's in the literature. You can find all kinds of different norms based on age and sex. Same thing for strength if you go and look for that. So when you have somebody that presents to you with limited mobility, probably the first thing you're thinking about is bony changes. Might be a joint contracture if they've already had surgery or trauma. Could be guarding. Certainly swelling is something of concern. You can obviously see that. And then also think of motor nerve, right? Musculocutaneous, radial, median, musculocutaneous, and radial. So any limited motion for motor nerves. But I would say majority are going to be the first two that you typically think about as a problem as you go through that. You can double check this by applying passive overpressure. We'll go into some specific joint mobilizations, and you'll have more of that in PT651, but we'll go through some of those components of extension. You should have a hard infield. When you go to passively overextend, you should bang, not hard, but gently bang the olecranon fossa with the olecranon. Flexion is going to be more restricted by the muscle mass. And then pronation and supination, radial ulnar, will have a capsular infield. Valgus, in a normal varus and valgus, when you test the ligaments, that should also have a capsular infield. This is probably relevant as we go forward in physical therapy. If you're working in an outpatient primary care setting or an emergency room, if somebody presents to you with elbow pain and they cannot fully extend their elbow, this research project that was done in an emergency department had 110 patients underwent a radiographic evaluation, and the inability to fully extend the elbow was found in 37 of the 38 patients with bony injury. Doesn't say where the bony injury is, you just know something's messed up with the bone, and that would be an indication that they need an x-ray. So if they present to you acutely and they haven't seen somebody else and they can't get full extension, my recommendation is get an x-ray. Okay? So that was pretty good sensitivity and specificity for the bone joint. Only one patient out of 54 who was able to fully extend didn't have the bone injury. So, do you have a question? Yeah?
Sorry,
Not sorry.
said the sensitivity since it was higher. When you rule them out,
So this is, so, yeah. So if they can fully extend their elbow, you with me? They likely don't have a bone injury. So so when the sensitivity is high, there's a true positive rate of a fracture. Cool? So there's interpretation, and then there's what it actually means, right? So a highly sensitive test, when it's negative, it's good for ruling out that there's a fracture. But when it's positive, you don't know if it's absolutely a fracture, but in this case, just that little simple active extension test was a pretty high recurrence or a pretty high prevalence of a elbow intra-articular injury. Okay. I just gave you all of this just to think about as you're going through your manual muscle testing, resistive function. You're testing the nerves as well as you're testing the muscle function at the elbow. So let's talk about the nerve pathologies. Okay? So neurology of the elbow are going to be these tissues you have to rule in and rule out. Cubital tunnel. Where's the cubital tunnel, Alex? Don't be looking around. I'm looking right at you. Ali. No. Not the cubital tunnel. Try again. That's the cubital fossa. Right word. Which side? Medial or lateral? Medial. So it's your funny bone. It's what you learned when you were 7 years old is your funny bone. That's your cubital tunnel. So the ulnar nerve passes right there on that side. Antecubital fossa, Alec. Median. Lateral elbow, radial. So if I have medial elbow pain, I got to make sure I got no nerve problems with the ulnar and median. If I got medial elbow pain, I got to rule out the radial. Cool? Makes sense? Above the elbow, because the radial nerve, actually I'll show you that here in a second. I'll show a better picture. This is an anterior view. They call it a tardy nerve palsy or a Saturday night palsy. I'll explain that a little bit as we go. So the sensory pathways. So did you all learn this trick in cervical anatomy and dermatomes and myotomes? If you put your hand in anatomical position with your thumb up, it goes C5, C6, C7, C8, C1. It goes top to bottom. Y'all got that? And then the Vulcan, right? What's the Vulcan? Ulnar, median, radial. You get those, you're doing great. You keep those all straight, I'm not too worried about if you don't remember the lateral antecubital fossa or the lateral cutaneous nerve off the musculocutaneous. What'd you learn? Confusion? What? Oh, you're remembering back to gross. Gotcha. Yeah. So the web space, the dorsal web space, that's radial. Yeah. Not everybody can do the little Vulcan sign, but that's the easiest way to remember that. And I mentioned this already, palpation's really important. Don't overactivate the muscles as you're going through that. Now, I am not going to ask you when the bones appear for secondary ossification. This crypto, this is a orthopedic surgeon punking of the residents that they ask them all these crazy questions when they do an x-ray of a youngster. So these secondary ossification centers develop as you're growing. The key is in red. When do they fuse? So for us, with somebody that's 15, 16, even 17, right, and they have medial elbow pain, their medial epicondyle doesn't fuse till they're 14, 15, 16, 17. We know boys develop later than women. Women typically are advanced and fuse earlier. And so you got to have an x-ray of both sides to see if it's a secondary ossification center or a fracture. So you might see a little prominence on the medial elbow, but you might have the same prominence on the uninvolved side. One is further away. Oh, that's a problem. Does that make sense? Okay. So I'm not going to ask you, when does the radial head appear? I'm not that big a jerk. But at the time, what I want you to focus on is if I ask you a question about a kid that's a young age, keep in the back of your mind, oh, that could be a fracture, or it could be that it just hadn't fused yet. So when I look at elbow injuries and I evaluate them, I sort of break them up into traumatic and microtraumatic mechanisms. Obviously, traumatic are going to be typically fractures or post-traumatic tissue adhesions. Certainly, they can get fractures in ligaments, and they can also have neuropathies. It doesn't have to be a fall. It could be a blow. Somebody could actually be in a fight or be in a motor vehicle accident. Microtraumatic injuries are typically overused from sport or work activities. Those, again, most commonly are tendinopathies, then neuropathies, and then degenerative changes like the osteochondritis dissecans. And you can develop ligamentous injuries, repetitive throwing activities. I try to differentiate it by location as I'm thinking. I try to break it up into these two differential diagnoses. So I initially tried to teach this to you all, but I stopped and I went back to the ligaments. But as you're examining somebody in real life, this is how I think. So if I have medial elbow problems, I want to make sure find out how much is the nerve involved, find out how much the ligaments are involved. This is really common, musculotendinous problems. Do they have a fracture from overuse or from trauma? Do they have osteoarthritis? I can't do a ton about osteoarthritis. I can do a little bit to help them. Same idea on the lateral side. So this is how I function in the clinic, but how I'm going to teach you is by tissue pathology. Do you all prefer it that way? You have no idea. So the way I taught you upper is how I think. How did you like shoulder? Didn't like it at all. Sorry. I'm trying to figure out what works best. So you'll give me feedback, see if you like this better. It's how I function, so I'm learning how you all function. So neuropathies. What are the typical signs of a neuropathy? Jacob. Perfect, perfect. What else? Perfect. What else? One more. Scan exam. Dermatomes, myotomes, and perfect. Deep tendon reflexes. Okay? So that's what you're going to do to rule in or rule out those involvement. I've already sort of told you medial elbow pain. You're thinking ulnar or median nerve problems, lateral elbow. So ulnar nerve path, primarily C7, C8, T1, comes behind the medial aspect of the elbow. And you can get entrapment up here where it separates between the bicep and the tricep, but it's relatively rare. It's much more common right here as it dives under the medial epicondyle. This is called the cubital tunnel. It's surrounded by the ligament, the posterior band of the medial collateral ligament, the edge of the trochlea, and the medial epicondyle sort of sits at the roof of that. Did you all do ulnar nerve tensioning? So what's the position for ulnar nerve tensioning? Cat eyes. Perfect. So elbow flexion stresses the ulnar nerve. So flexion activities, when I'm up here, I get symptoms. I'm thinking nerve, ulnar nerve. So this is a fancy CT scan that I got from an orthopedic surgeon a long time ago. Elbow extended. You see sort of some redundancy, a little looseness. It's tensioned as it starts to flex up around 90 degrees. Excessive stress of valgus will also cause it. Yes? I like it that you're thinking. I like that you move as you think. That's exactly how I got through school. Most ulnar neuritis is secondary to stretching or tethering of that ulnar nerve, so something with flexion activities. You'll get numbness and tingling in the ulnar distribution. You might have some weakness. Grip, as you go to do grip strength, most of your power in grip comes from the ulnar side. If you make a fist, and you'll see the third and fourth metacarpal, or the fourth and fifth, if that's how you think about it, rotate around this central metacarpal. That's where the grip power comes from. These, you almost never fracture. You can. When you have a boxer's fracture, right? Classic junior high, high school boy injury, right? I'm picking on the guys today. So they hit a locker because the girl broke up with them, or somebody broke up with them, or they lost something in a basketball game, and they typically break the third or fourth metacarpal. So the power of grip comes from the ulnar side. In a long-standing problem, you'll see atrophy of the hypothenar. That's really rare, but you can see it, or somebody that's relatively old. So Tinel signs, the ulnar nerve is at the cubital tunnel, so you're going to poke back here. Sometimes when they're flexed, really aggravates them. You can do a Tinel's. The other place is in the hand. What's this tunnel called? Guion. Perfect. Good. The test you can do is a prolonged elbow flexion. This is called the Thayer or Bueller test. So if they have symptoms after within 30 seconds, that could be a positive sign for ulnar nerve. Not the best sensitivity and specificity in the world, but it can be done, and it's a test that's really easy to do. You just position them and actively have them hold that. Some doctors will apply pressure while they're doing that to aggravate that. Not any sensitivity or specificity. Median nerve, most commonly we think about it at the carpal tunnel, but you can also get compression at the pronator teres, and you can also develop what is called an anterior interosseous syndrome. These three muscles, flexor pollicis longus, flexor digitorum profundus, flexor pollicis longus, and the pronator teres, take your fingers and go tip to tip. If you cannot go tip to tip, you have an anterior interosseous nerve pathology. If a person does this, makes like a duck, that's a problem. They can't go tip to tip. That's how you sort of assess it. It's all motor, so they're not going to have sensation losses. From pronator teres syndrome, you can get all the same symptoms distally in your hand as you would for carpal tunnel. So now this is the median side. So my index and long finger are going to be numb and tingling, maybe my thumb and my palm. I can have weakness in both pinch and in grip. Fine motor activities, writing, it starts to bother me after I've been writing for a period of time. Again, if it's a long-standing nerve injury, you can see wasting of the thenar eminence. So median ulnar, median ulnar. These are going to be worse because it runs in the front with a median nerve bias. So elbow extension, wrist extension, and supination, right? The pronator pronates. So if you put them in supination, elbow extend, wrist extend, that's going to aggravate median nerves. Make perfect sense? So pronator teres is often associated with people doing a lot of work with their arms, plumbers, carpenters, weightlifters. It won't be focused on the elbow. It's more in the medial forearm. So it's a little bit distal. They have increased symptoms with that tensioning. They feel better with rest. If you load the pronator teres, right, if I resist pronation and it hurts in my forearm, not on my elbow, I'm thinking nerve. If I hurt on my elbow, I'm thinking medial elbow pain, medial epicondylitis. Does that make sense? So this is a test that Dr. Hazel uses to help with identifying pronator teres. So basically, starting with their arm with their elbow flexed to 90 degrees, and you're going to try to determine if it increases distal symptoms or more at the medial epicondyle. So you start with the elbow flex, maximally supinated, so I'm stretching the pronator, right? I resist them going into pronation, so I'm activating it, and then you passively extend their arm. If their symptoms are medial, that's more medial epicondylitis. If it's distal, it's more pronator teres. Make sense? I talked about this already, the anterior interosseous. Tip to tip, or tip to tip, means everything's working. They can't go tip to tip. It's all motor, so it's just going to show up with forearm pain. So it's not going to have the sensation. So you can still have numbness and tingling, which could be a median nerve, but you might not have that in every patient if they have an anterior interosseous nerve, since it's a motor. You can aggravate their symptoms by compressing along that medial forearm, sort of along walking your fingers down through that area, see if that recreates their symptoms of pain, but they might not have a neurological component with that. Radial nerve, it's the serpentine nerve. It comes out of the axilla, wraps around on the back side of the humerus. That's where you can get what they call Saturday night palsy. So if I rest and fall asleep on a firm surface and my arm and my head's over there, I can compress my radial nerve. I wake up, what happens? I got wrist drop. Momentarily or for a long time potentially, I can't extend my wrist. Freaks people out. You get lots of early morning phone calls when you're an athletic trainer, when the guys are out drinking. Wraps around the lateral head of the triceps. goes through the lateral intermuscular septum and dives underneath the supinator, which is the radial tunnel. So now we're on the lateral side. This is the imaging coming down from the axilla, comes out of the intermuscular septum on the lateral side. Here's the nerve without a muscle. Here's the supinator. So that deep part of that nerve, once it goes underneath the supinator, is called the posterior interosseous nerve. So it's a differential diagnosis for lateral epicondylitis. The deep branch of the radial nerve travels through that radial tunnel. It's about 5 centimeters below the radial head. So typically when you have lateral elbow pain, this is why palpation is so important. If it's tendinitis, it's going to be up here on the lateral epicondyle. If it's lower, 4 or 5, 2 inches lower, that's more posterior interosseous. So a classic way of figuring this out is you give somebody one of those elbow straps, right? You all know what I'm talking about? Those counterforce straps. And they come back and they're like, I am dying. Why? Because I've just compressed the nerve. So that's a really good way to diagnose it. It doesn't make your patient super happy that you just gave them one of those and they said, and you told them to wear it. But that's a real easy way to figure out what's going on. I've had that happen. Floor, basically the deep head is the supinator. The ceiling is the supinator muscle. The sides are basically these other extensor carpi radialis and the brachialis. Again, the posterior interosseous nerve is your I love you sign. Am I saying that right? Okay, and you said that's sign language, right? American Sign Language? Very cool. So extensor indicus, abductor digiti minimi, and extensor pollicus longus. Other muscles too, but those are really good muscles to test because they don't attach at your lateral epicondyle. So you can load those a little better. Radial nerve palsy is going to give you symptoms on the back of your hand. They're going to be weak and wrist extension, active compression of the radial nerve. Your elbow is going to be flexed, forearm pronated. So this is the same test going the other way, right? So if you take your elbow, you pronate it, you resist supination, you passively extend it, that's activating the supinator and would aggravate that. Sorry. So that would be a compression on that radial nerve. If you see weakness in the tricep, look at the neck. If they can't extend or they have abnormal deep tendon reflexes or weakness, it's probably more proximal, not coming from the elbow. Unless they tore their tendon. Pretty rare, but I guess it can happen. I haven't seen too many tricep tendon ruptures. So what do we do about nerve injuries? We protect the nerve. Can't exercise these well. These have to be rested. You have to manage the inflammation. Splinting really helps. So proper wrist and hand splints. Modalities, gentle mobility. Don't get crazy with your instrumented, your devices really rubbing the crap out of them. Once you irritate a nerve, they stay irritated for a while. Ice is not well tolerated in nerves, so you got to be careful with that. So I'll stop there. It looks like it's right at 3 o'clock. Give you a 5-minute break, and then we'll come back.
It's been a long day. I'll try to think.
And then we have journals for
I
Sunday.
know. Dr. Well, we got one of your articles for Journal Sunday today.
No, you did.
Oh, we did.
Which one?
The one about the self-efficacy for home exercise programs.
Oh, Dr. Tyken.
Yeah, you're looking the last time. It said you came on. It said you came on the top of the show. You wrote this, and your name was the only one I recognized off to it.
And those are my associates and my doctoral students. I'm overseeing her with wherever that's from. Presiding. So I have a job where you're yeah, I'm trying. Trying to keep you guys awake. Failing miserably. Zach, can you hear me okay? Chuck, can you hear me? Okay. You're allowed to talk today. Somebody got smart. Yeah, exactly. All right, let's find your seat. All right, everybody, let's find our seats. All right, I'm going to talk about ligamentous instabilities. So, as I said before, you have medial and lateral collateral ligaments. With different sporting events, you can have a traumatic episode. So this is a elbow dislocation, valgus overload injury during a snatch. Much more common is repetitive microtraumatic overload. And what I want you to think about when you're taking a history and you're asking your patient what's going on, these loads can occur not just in baseball players, but it also can occur in workers. So even though we're talking about ligamentous instability, there's 3 or 4 structures that could be involved with this medial elbow pain. So obviously, the medial ulnar collateral ligament can be stretched out or torn. Secondary structures can be aggravated. The pronator teres, the flexor carpi radialis, and ulnaris help to provide some stability. But the other main stabilizer with valgus overload is the radial head into the capitulum. So that compression of the radial head into the capitulum can also provide stability and get damage. Radial head fracture, gradually like a stress fracture or even a trauma where they fall. In addition to that, you can sort of see how that valgus overload is going to compress that. The other area that gets compressed is this posterior olecranon. So they can have posterior medial elbow pain, so the edge of the olecranon can get aggravated. Obviously, we see this a little bit more in throwing athletes, but somebody that has a lot of valgus, that does a lot of flexion extension, can develop that osteochondritis dissecans, and then they can stretch the ulnar nerve. So all of that can sort of present with medial elbow pain. So you got to keep all of that in your brain as you're ruling in and ruling out all of those pathologies. So how do you stress the medial collateral ligament? If you're in full extension, yep, that's my man.
Yeah, I had to think of one. Why is it that, like, with throwing injuries, like, they always talk about, like, curveballs and specific types of pitches that are, like, worse for, is it just, like, the motion that you throw with, or?
No, they don't know how to throw it. To throw a correct curveball, where's my throwing athlete? My non-throwing athlete? Inside joke in Lexington, right? So how do you throw a curveball? Do you change your arm slot, or do you?
Came through more angled, like either do from angled or over top.
Gotcha. So it's actually with what you're doing at your fingers. So you snap your fingers. So the arm slot should be the same. Actually, curveballs usually are thrown a little slower, so there's not good evidence. People just don't teach it right. So that's one of the reasons why they don't let them do. They suggest you don't throw a curveball until you're shaving or whatever. So, but there's no strong evidence that it overloads the ulnar collateral ligament. It's sort of a wives' tale. It's an urban legend, if you will. So, there's 3 portions. When you're near full extension, which ligament is going to be under the greatest stress? Say it, Grace. Medial. Which part? Good. Anterior. Good. In extension, anterior band. As you flex, more the posterior band. So typically when we do valgus stress, most people have done it in near full extension, like 10 or 20 degrees of flexion. Some people do it laying on the table. That's the way Dr. Hazel showed you in the video to do that test. They don't have the arm stabilized. I've seen a lot of doctors just put it up underneath their arm and do it that way. Oh, sorry. Not great sensitivity or specificity. A better test is called the moving valgus test. The advantage of the moving valgus is you flex and extend, so you stress both bands as you go through that motion. The arm's abducted to 90 degrees. The elbow starts with it flexed. Move them into external rotation. You apply a valgus torque, and then you flex and extend the elbow. So you basically passively flex and extend. So as you're thinking through this, static test, static structures. Active stress, active structures. That's sort of consistent. Sensitivity, 100%. Specificity, 75%. So pretty good at ruling out. Now, the problem with this study, it's only been done by one person. And it's also been done by the best elbow surgeon at Mayo Clinic. So you think he sees the average Joe? No. So it needs some more repetition of testing. There's another test called the milking maneuver. Again, this is with the elbow bent. You're going to load them have a fulcrum at their elbow and load them into external rotation. With the arm at 90 degrees, it's going to bias more of the posterior band. That's why the moving valgus is probably the best, because it gets both anterior and posterior. Nothing wrong with this test. Again, not much sensitivity or specificity out there, but it's a commonly used test in the clinic. MRIs are very common with elbow injuries. An MRI signal actually helps you in determining what's going to happen with their rehab. So this is an article by Dr. Kim Dr. Kim is out in Korea, but he does a lot of research. So he identified that low-grade MRIs did the best with rehab. So 31% of the symptoms improved, or patients with these low-grade signals improved with rehab. Most of them, 75%, returned to competitive athletics, but it took half a year. Okay? So if they have a complete tear, didn't do well with conservative rehab. So this is setting patient expectations as you rehab these athletes. Non-operative management, if it's a partial UCL, you can get them back to sport or sport-like activities, maybe not full go, in 12 to 24 months. This is a systematic review. These were the components of that rehabilitation. The rest period was with a brace, so they put them in a hinged brace, most of them, stretching and strengthening, interval throwing program. If you need one, I have not hundreds, but I have several, if you ever want one. And then platelet-rich plasma injection. So that helps the healing of the ligament. We do that here at UK, our sports medicine doctors. Post-op, surgical, typically there's a period of immobilization. Usually we restart mobility at 2 to 4 weeks. And then at 4 to 6 months, we start the interval training throwing program, post-op UCL. The key with that, get full extension. You got to get full extension, very much like ACLs with rehabbing those. This is a less common, so I'm gonna introduce this to you. This is a posterior lateral rotatory instability. It's a fall, typically a fall on an outstretched arm in a twisting maneuver. So you notice the hand is sort of supinated or externally rotated, and they're falling in a funny manner. They get a subluxation or a complete dislocation of their elbow. So they might get up and they say, I hurt my elbow. Those are the classic patients that come in 2 to 3 weeks later and say, I fell, I didn't get a fracture, doctor said my x-ray was fine, but my elbow still feels funny. Something doesn't feel right. Those are the patients you want to do these assessments. So O'Driscoll, same dude that did the other one, categorized these as a partial perched dislocation, so a grade 2. So the ligaments around the lateral side, both the radial collateral and the lateral ulnar collateral ligaments have been torn, but they haven't torn the medial side. And then a stage 3B, everything's torn. 3A is the medial collateral. So that's typically going to require a reduction. So it's out of place. You got to put it back in place. So how do you stress it? You can do a Vera stress test. Same idea, almost full extension, bend them a little. That gets a part of it. And then the other test is this push-up test. There's another test that O'Driscoll describes. It's a little more complicated, so I thought this would be a good introduction. So you basically have them anatomical position, supinated maximally, and they push themselves out of the chair. So they're basically have to have a chair. What you're looking for is symptoms of discomfort, apprehension. You might see a little dimpling if you look closely at the medial epicondyle. So it's just an active test, but you have to watch and ask them if that bothers them or recreates their symptoms. So I've picked up a couple of these in skateboard guys that it fell and hurt their elbow and didn't know exactly. X-ray was negative, but they had a little hypermobility. The other one, in those of you that like to treat kids, I know there's a few folks, this is a pediatric injury. It's called a nursemaid's elbow. You dislocate the radial head. So the mom or the nursemaid grabs the kid as he's trying to run out in the street and jerks him back and inadvertently dislocates the radial head. This is typically reduced well and do pretty well with non-operative management. So this is a young population. 3, 4, 5-year-old kids have just learned to walk and running around. If it happens in an adult, typically they're going to need surgical repair. So with those mechanisms of lateral instability. Reduce the provocation. Ligament braces or hinge braces are wonderful. Gradually get motion strengthened after about 6 to 10 weeks once the ligament is calmed down is a good treatment approach for these medial or lateral ligament instabilities. Cool? Tendinopathies. So back to Cyriac's concepts. These are active structures, so they're going to hurt with active range of motion. Resisted range of motion is going to increase their symptoms, and then lengthening the tissue in the opposite direction. So for medial epicondyle, I want to go into wrist extension passively, supination to stretch the pronators. For lateral epicondyle, I want to go into flexion, maybe finger flexion, pronation to stretch the lateral side. Cool? Resistance, wrist extension, lateral epicondyle, wrist flexion, maybe gripping for medial epicondyle. Okay? Does that make sense? Don't make it any harder than it has to be. I mean, you can make it as crazy as you want. Typically, these are more chronic, insidious onset. They talk about pain with the activities of daily living, reaching out, picking up a cup. This is typically a degenerative process, some kind of eccentric overload, and the tissue has failed. You're going to see this a lot in the clinic, especially if you work in a facility that does a lot of workers' comp. This is a lot of workers' comp pathologies. Medial epicondylitis, medial elbow pain, resisted wrist flexion, resisted pronation, lengthening the wrist flexors, aggravate that. No great fancy test that I can give you for those. More common is lateral epicondylitis. Our wrist flexors are stronger than our wrist extensors. I think that has something to do with it. If you're doing a lot of grabbing and lifting, that loads that lateral, and the wrist extensors aren't quite as strong. Reaching out, shaking somebody's hand, or grasping an object aggravates their symptoms. Localizes the pain to the lateral epicondyle. Most commonly tendon involved is the ECRB or the ECRL or the extensor digitorum. Those are the most common tissues that are involved. They've given names to these tests, but it's basically wrist extension. So Cozen's test is patient seated, elbow flex, ask the patient to extend and radially deviate their wrist, apply a load, and see if that reproduces their pain at the lateral epicondyle. Mills is basically passively doing the reverse, not so hard. Passively pronate and flex the wrist. Ow, that hurts because you're loading that and lengthening that tendon. So there's been a couple of systematic reviews. Nobody really agrees, I think because we don't always do a great job diagnosing all the correct symptoms. Typically, relative rest, reduce the aggravating activity, some kind of external support. The literature suggests that maybe a wrist extension splint is better than a counterforce so they can't grab and do things. All kinds of modalities to increase blood flow. Then you're going to progress in a strengthening progression, isometric, concentric, and then eccentric strengthening. And then as they get better, you're going to get them back to work-specific activities. Pretty straightforward, a lot of different variations here. Not all of this has been well supported. So this is from a research project that we did at Toyota. We had patients presenting with lateral epicondyle pain. This is a retrospective review. We put them in a wrist splint. They typically wore that for about 5 to 6 weeks. We educated them on risk factors. We did blood flow facilitation, massage, mobilization, anything we could, ultrasound to facilitate blood flow. We worked proximally, stretching the tight anterior muscles, strengthening the scapula. We found that scapula fatigues a little faster in these patients. And then we did a static progressive loading. So we start with the elbow bent. Once they're pain-free here, then we can lengthen them out to 45 degrees and then full extension. So gradually increasing the load across the wrist extensors. That's usually done somewhere around 7-8 weeks. So we let them calm down first. And then we do sports, or not sport, but work-specific activities, including eccentric training to help facilitate that. There's some pretty good evidence in the literature. Once they're calmed down, to do some eccentric training is a good way to facilitate recovery of lateral epicondylar patella tendonitis and also even shoulder tendonitis. We got 85% or 84% back to work, not 100%. Some we lost to follow up. Some of those ended up going to surgery. Smaller percentage though, right? 15%. Improvement in grip strength, improvement in mobility after those visits. So it took us on an average of about 18 visits. It's a gradual burn. It's a slow process. If they do need surgery, what they typically do is they'll cut open arthroscopically or with an open technique, remove the degenerative tissue to facilitate healing, and then they suture that back up. Sometimes they don't even have to suture it. So it's pretty aggressive in there to remove anything that aggravates that. There is a phenomena. It's rare. It's called a synovial plica. Did somebody have that? Do I remember somebody talking about a synovial plica in the elbow? Was that you, Dakota? It was in your knee. Okay. So you can get a plica in your elbow. Who knew? Right? So it's basically just a little fold of the capsule. You can only see that with MRI. You can sort of see that progression of the different slices of the MRI. It sort of gets entrapped between the radial head. That's going to be a little bit more of a posterior joint line pain. You're not going to palpate or feel that. So that's something that might present as a differential diagnosis. So if they have some clicking or popping, it might be, and they're not responding well to rehab in the first 2 or 3 weeks, you might want to consider having them or the doctor order an MRI. Other tendinitises, more rare. Triceps tendinitis, obviously, that's going to be irritation back on the posterior aspect of the olecranon from repeated motions. You might see this from these type of activities that are more demanding. The other side, symptoms of this are going to be classic achiness, increased pain with activity, better with resting. They might have some swelling, so it might look like bursitis, olecranon bursitis, usually not quite as superficial, more in the tissue. Olecranon bursitis, obviously, we talked about the big concern there. People who crawl around on their hands and knees, elbows are more likely to get it. I've seen this a couple of times in patients wearing from rotator cuff disease. If they have a rotator cuff surgery and they wear a sling or a proximal humeral fracture, if they wear a sling for a long time, that doesn't fit very well. Obviously, you're going to try to control the swelling, take the pressure off, and really watch for infection. That's the big thing to do there. There's no exercise or fancy trick. Light compression seems to help people with olecranon bursitis. Biceps tendinopathy, more common that you'll see a biceps tendon get torn, but you can get biceps tendinitis. A complete tear is going to cause one of these little Popeye signs. You can tear it proximally or distally. Probably distal is more common. Proximal is more with shoulder pain. They might even feel or hear a pop when it actually happens. Looking for asymmetry. A lot of times if it's acute, it'll be black and blue. So it's pretty easy to pick up. There is a palpable defect. It's called the hook sign. So take your arm, bend your elbow to 90 degrees. Don't contract your muscle, but just poke your finger right behind the biceps tendon. You should feel, unless you have a torn biceps, you'll have to turn it sideways. You might be able to feel it that way. So I usually just have them bend their elbow, and then I put my finger right behind. That's the hook sign. So you can hook your finger. Can you all feel that? What's that? That's good. That's a negative. If you can't hook it, that means it's gone. It's torn and rolled up into your upper arm. So you want to be able to hook it. You don't have one, Zach? You don't know? You can't feel? Somebody help him palpate. Low demand patients, people that are older that might not have to do a lot of heavy carrying. What's the other muscle that flexes your elbow? Brachialis. So you can function without a biceps if you don't have high demands. Most people get these fixed, so they're going to basically drill a hole through the radial tuberosity and reattach the tendon. If it's been chronic, it's really hard to fix. So you don't want these to sit on. You don't want to sit on these for weeks and weeks and weeks and say they'll get better. It's better to get these fixed earlier than late. Typically, they're immobilized for a few weeks, 5 to 6. Then we start range of motion, and then about 10 to 12 weeks, we start strengthening. That's how long it takes for that tendon to grow in well to that bone, and it has a good, firm construct. So the last area we're going to talk about are fractures. Most of these are traumatic mechanisms, but you can get them from overuse. So this is the joint mice, osteochondritis dissecans, medial epicondyle, and olecranon. These are most common in throwing or overhead athletes. These can occur to anybody. So anybody, any walk of life, you can develop one of these. The terrible triad is a combination of a fracture and a dislocation. Wonderful case for you to write up if you get one of those out on your clinical. Hopefully you won't have to see that right away. So osteochondritis dissecans is a wearing away of the joint. It's an inflammation of the bone and cartilage. It can most commonly occur posteriorly and laterally, but it can occur on any surface. Here you can sort of see the radial head and the degeneration of the capitulum. That's called Panner's disease. If the CI is giving you a little grief and asking you, hey, this patient's got Panner's disease, they're not going to die. They just have an osteochondrosis of the capitulum. So it affects the capitulum, trochlea, and olecranon most commonly. Here you can see a little secondary ossification, so you know that's a young person with the medial epicondyle. This might be a avulsion, right? I have no way of knowing until I x-ray the other side. Can't tell by looking. So mechanism is the repetitive high stress, loading the elbow joint repetitively that fragments this tissue. They typically present with stiffness, maybe some swelling. They might have a sense of giving way or instability. Most of the ones that I have seen have been more popping and clicking, and they'll say, I can't straighten my elbow, and then I'll do some other stuff, and then I can straighten it. So something's blocking it. It's in the way. So you'll have episodic limited mobility or swelling. Only way to confirm it is with radiographs or MRI. This is what the surgeons consider. If it's loose body unstable, they might have to go in there and remove it. If it's a big enough loose body, they can try to reattach it. Grade 1s and grade 2s are going to be modified activities. See if we can change their mechanics, do stuff like that to help them get more functional. Stage 3, if they're really symptomatic, they might go in there and scope them and clean them out. And then you're going to deal with postoperative rehabilitation of getting swelling under control and getting motion. A bigger injury is a medial epicondyle avulsion. So here we have a significant displacement of the medial epicondyle. Big segment like that's probably going to get reattached with the screw. Again, associated often with these young throwing athletes or gymnasts doing activities. Same presentation as a UCL or a medial epicondylitis. So you can't truly differentiate that. You might be able to get a sense if they have more night or resting pain. Does that make sense? So if I'm active and it hurts, that could be tendinitis. It should go away with rest. But if it still is aching pretty good, resting pain makes me worried about bone and joint problems. So that's why it's really important. Remember what I talked to you about 15, 16, 17 years old before they completely fuse with these medial epicondyles. Olecranon stress fracture is the other common injury. This is a little more posterior. but presents with medial elbow pain, could have ulnar nerve symptoms. The same issue that causes the osteochondritis can gently crack and fracture that olecranon, that repetitive valgus load of poor throwing mechanics. Again, may be more uncomfortable at resting, usually aggravated with activity. These can be treated non-operatively, but a lot of people don't want to wait. A lot of these 16, 17-year-old kids want to go and play at Bellarmine or Transylvania or UK or USC, wherever, so they want to have it fixed. So they're going to manage this with a screw. I've had one patient that needed 2 screws because he broke through the first screw. Swelling, bruising, point tender, if they fall on their elbow, they can get an olecranon fracture, so that's going to be a more traumatic mechanism. So we basically have 2 types of mechanisms, a fouche or a faux. Fouche, I fell on my hand. Faux, I fell on my elbow, the tip of my elbow, okay? These are the classic signs of fractures. Now, in your all's world, as you all are becoming more and more independent practitioners, you might see these walking in off the field. So you got to know signs of fracture. So big signs of fracture is limited motion, swelling, localized point tenderness. They may or may not appear to be displaced. If it's just a little crack, it's not going to look displaced. We talked about the active extension test, and certainly we want to check neurovascular status. Has anybody ever seen an acute fracture or had an acute fracture? Anybody fractured their forearm or wrist or elbow? What'd you fracture? Okay. Gotcha. What'd you have? Tib fib. Nice. Didn't hurt at all. So when you fracture something that big, you certainly feel it. But some of these, you guys, as physical therapists, often we treat in the background once somebody else diagnoses. As an athletic trainer, I've seen a lot of these. And so you have more of an acute management. So what's the management for a fracture acutely? Nicole, I saw you say it. Splint it and x-ray it. Yeah, splint it as it lies, x-ray it. That's the best thing. Check neurovascular status. If you're in a location where you don't have x-ray service, if it's a dislocation and they're neurovascularly impaired, you might have to reduce it. Don't reduce it unless you know how. Okay? So if y'all are starting to work as independent practitioners, those might be things that you think about. Common mechanism of injury, radial head fracture. A lot of these are not displaced, so they're treated non-operatively. Fouche is the more common mechanism. Swollen joint, pain over the lateral elbow. They will not like pronating and supinating because that's rotating the radial head. So that's usually a good indication of that. You certainly can have a fractured dislocation, like a posterolateral instability with that. That's a pretty obvious deformity. These are not. Okay? So if they really don't want to move and they haven't been x-rayed, you might want to get them x-rayed before you start trying to move them. X-ray signs, if you do get to order images that are classic indications of fractures, have you all had this already? Fat pad signs? Have you all had imaging? Yeah, so you all know fat pad signs and sale signs for swollen elbows, displacement of that. A Monteggia fracture is a fracture of the proximal ulna. These are more grabbing and twisting injuries or impact across the forearm. Okay? Not typically a fall mechanism, but more of an impact across that. Obviously, with this much displacement, it's going to need to be fixed, and you got to check neurovascular status. So they're probably going to be compromised neurovascularly, or at least neurally, when you rehab them. So you got to definitely watch these as you're recovering from that. There's lots of types of elbow fractures. These are called supracondylar fractures. There's lots of different classifications. But basically, they're extra-articular, intra-articular, or both. Extra-articular means the condyles are saved. It just fractured above. Less chance of arthritis. with intra-articular or combined, they disrupt the articular cartilage. That's how you get those valgus and varus deformities. We see that a lot with kids. Kids actually do really well with just set them, immobilize them, let them heal, and let them start doing stuff. They're not as afraid as older patients are to get moving. So obviously that's going to require an x-ray to diagnose that, and many of these are surgically fixed. What are your two mechanisms of operations? What's this image? Anybody ever seen it? What is it, Grace? Perfect. Total elbow. What's this? It's a mess, huh? Is that what you said? What is it, Rob? ORIF, yes, sir. Open reduction internal fixation with plates and screws. Plates and screws. Plates on the lateral side to give it its abutment, screws to stabilize the fractures. Hopefully not through the joint. So if that screw gets a little proud, what happens? Arthritis, rubbing prevents range of motion. So you've got to be cognizant as they're healing how things are healing and making sure something doesn't get too proud. Terrible triad is a fracture dislocation. Classically, the radial head and the coronoid get fractured. You become unstable, and then you have a posterior lateral dislocation. So they dislocate around that lateral side, and it can go anteriorly and posteriorly. A coronoid fracture, it's a large chunk. That's not such a large chunk, right? Still, most of the arcuate is intact. Might not be fixed. Might not be fixed. They knocked off this big chunk right there. That'll have to be fixed. Foosh, fell, hyperextended injury. They'll have, obviously, a lot of pain and swelling if they do this. Clicking, they might not want to move their elbow. They'll be unstable, potentially both in varus and valgus. So we check that and check neurovascular status if you're trying to evaluate that. Post-operatively, rehabbing these can be a little bit of a challenge because there's so much swelling. So you got to control pain and swelling. This is true for any kind of fracture, but certainly also for a dislocation. Gentle motion. If you force motion in an elbow, what happens? Any idea? Y'all ever heard of a heterotopic ossification? Y'all talked about that in healing? Yes? No? Never heard of HTOs? Okay. I'll show you a picture here. So gentle motion. Strengthening is always delayed with these, probably somewhere in the neighborhood of 3 to 4 months, depending on how they're healing. You got to watch for complex regional pain syndrome on these folks. They can develop some nerve irritation. The autonomic nervous system can get really flared up with these patients. There's been a lady coming to our clinic. She had a frozen shoulder, radial head fracture. We've treated her for a year for complex regional pain. A couple other pathologies just to mention that didn't fit in perfectly. Osteoarthritis of the elbow. This is typically common in heavier laborers. People like to lift a lot of weights or their job requires them to do a lot of activities. A lot of farmers develop this over time. Patients that have rheumatoid arthritis, one of the most common joints is in the elbow that they develop osteoarthritis. We think of OA typically in load-bearing joints, so knees and hips are much more common than elbows. They'll present a lot like that osteochondritis dissecans, locking, crepitus with motion, occasional pain and swelling, but not constant. Unfortunately, we don't have a great physical therapy intervention, other than some education, maybe some modalities, and maybe some protective orthotics in their resting splints to help them reduce that. Yep.
What's the difference between osteoarthritis and osteochondritis?
Gotcha. Osteochondritis discecans is usually the focal area. Osteoarthritis is more panacea, but they're a continuation. So osteochondritis starts osteoarthritis. Or a prominent, malplaced screw develops osteoarthritis. So I'm a little hard on doctors, but I've seen doctors have a lot of issues. And especially if you work in a place where you don't have a lot of orthopedic surgeons, you have one or two, they might not be experts at fixing all of this. So just to be aware of that. This is heterotopic ossification. So you basically have a bone bridge between the radius and the humerus. There's actually a bone bridge that's developed between the radius and the ulna. This is a common complication post-surgery for fractures, right? Post-dislocation occurs between 4 and 18% of all patients, 0 to 50% in fractures. A lot of times this is aggressive early motion or not well stabilized fractures. So it's micro motions. They can use strong anti-inflammatories, but at this phase, all the joint mobs in the world isn't going to fix it. You're going to have it surgically removed and then treated with early passive CPM type range of motion to try to hopefully prevent it from reoccurring. So if you start pushing on a stiff postoperative elbow early, you can cause that. So that's an issue that we have to be careful with. So gentle motion early on, trying to help them facilitate that's really important. Probably one of the things you're going to see postoperatively more commonly is a contracture. And so a stiff elbow is really common. Post-dislocation, post-fracture, long-standing components. So they're going to have limited active and passive range of motion. You're going to try to assess those, but typically they'll have mid-range motion, excessive contractures at the soft tissue. So painful at the extremes of motion for them. So as you push them into flexion or push them into extension, you're going to have to evaluate what's going on with their soft tissues, and that's where the joint play assessments are really important that Dr. Hazel has on videos and we do in laboratory. Range of motion exercises are really good to avoid that. We use a lot of splinting, so static splinting are really helpful to protect them. Which motion is more important, flexion or extension? For function, flexion. In the knee, it's extension. You can walk. It's hard to sit down with the inability, but I can walk with a stiff, straight knee. But if it's a bent knee, I put a lot of load on my extensor mechanism. So the joint mobilizations of elbow distraction, humeral radial glide, humeral ulnar glide to gain extension, to help them gain full extension, and then humeral radial glide ventrally to gain flexion. Okay? Cool. How was this? Better? Yeah.
So earlier you mentioned like you can have like the radial abstractor and frozen shoulder. Which one would you work? Would you work on the elbow first and then make your shoulder, or would you both do one?
Yeah. So she started with wrist, but she couldn't lift her arm. They were seeing her compensate. So they started with her on the wrist. That was her primary problem. And she had frozen shoulder, so they sent her to me probably about 2 or 3 months into her, after she's out of her cast and all of that. It was distal. It was more distal in the wrist. She was ATVing in another country, put her in a big cast. She's a UK employee. Didn't get operated on for like 4 or 6 weeks. Huge, big splint. Got it operated on. Had all kinds of problems. She's got some contractures in her hands. Got a lot of finger limited motion. So she got complex regional pain syndrome. So we were treating a lot of stuff. But if it happened more acutely, this is primary, this is secondary. Does that answer your question? Okay. Did y'all like it by the tissue? So when I evaluate, so tell me right now, because I'm working on the hand stuff, I did it by location, but I can do it by tissue. Like when I say location, right? You have medial You got problems on this side of the wrist, you got problems on this side of the wrist, you got problems here, you got problems here. That's location. That's how I think, because I differentiate. Is this a nerve problem, a bone problem, or a ligament problem? You like it that way? That's by location. Tissue. Do it both ways? We don't have enough time. People like it both ways. So clinically, by location is how I do it mentally. Yeah. All right. So if you don't like it, tell me, and I can maybe audio tape them the other way. Like I did up there. Well, I've already done it by location, so it will be given to you that way. It seems like there's an unequal sample, so it sounds like I need to give it to you both ways. But I don't have time to do it by both ways in the lecture. But I'll try to record something for you. Did you all get the guys in Hazard in Kentucky, Hazard in Lexington, did you all get the labrum? So I put that in the shoulder special test. It's in the shoulder module. I'm trying to go faster. It's a lot of stuff to cover. Hey.
First of all, thank you for those practice questions. I really appreciated that.
You're welcome. I'm glad you asked.
Yeah, I was kind of
really
nervous.
Smart. Why?
Well, Dr. Johnson did that in the spring. He gave us like 5 practice questions, and then like gave us a week or so to do them, and then like went over them with us, and then I was like kind of more aware of like how to do that stuff.
Yep.
So I just thought that was.
I thought that was very fair, and that's pretty much how last year's test looked. It's a little different because I'm teaching it a little differently, but for the most part, that was the same. What was your other question?
My second question, I asked Dr. Casey, but he doesn't have like a straightforward answer and wasn't really sure, I guess. So we talk a lot about like throwing athletes, but have you ever seen like the difference between like throwing athletes versus like volleyball players who are more like force contact and like different body positions when making contact?
I consider them in the same world as throwing athletes because they cock their arm.
Yeah.
They come through, which they can lead with their elbow. Yeah, they make a contact, but then they still follow through.
Yeah.
Now, the big difference for dealing with a volleyball player is they're up off the floor, so they really need core stability when you're treating them, as opposed to those guys that step and land.
Yeah.
So they need a lot more work here.
Okay, cool. That's what I was thinking. Thank you.
You're thinking correctly. Hey, Nicole.
I just had a clinical question just
Sure.
about, well, really about me, but I'm just curious. Well,
Are you wounded again?
no, I am, but not in the upper extremities. I'm dying slowly, apparently.
Well, we all are, sort
This
of.
is the
I'm a
most,
lot closer to being dead than you.
this is the most injured I've been in a long time. So, but I'm just trying to like clarify because when I was in high school or whatever, I actually had, they called it tendinitis in my elbow, but it was on the medial side right in here.
Medial epicondylitis is possible.
So would it be epicondyle? Because that's not. Would it be the tendons though? Because the tendons. What tendons would it be? Sorry, I'm just trying to, because you know.
Pronator teres, flexor carpi radialis, flexor carpi ulnaris,
Through here?
palmaris longus.
Okay.
Could be.
Oh, yeah, 'cause it goes through.
Yeah, they all attach right there.
Okay, because I was just curious, because the other part of that is like now I can tell like when I do snatches, because I weight lift. When I do snatches, sometimes I can feel my elbow popping out forward. Is that from those tendons not?
Could be
stable
instability.
anymore?
They need.
Okay.
Well, we'll be interested to test you tomorrow
Okay.
for valgus instability. You
I
could
was
have
just
some.
curious.
It could be.
Okay. That's all I wanted. I
No,
was just kind of
that's-
like.
That's why you have to do the whole exam.
Yeah. Okay.
Hi, I just have a quick question about contractures. Can it happen in any tissue?
Sure.
So like tendons, ligaments, joint capsule?
Tendon joint capsule. A contracture in the in the tendon would be really considered scar tissue. It still could limit mobility, but his fracture by definition are easy.
Okay. All right. So thank you.
Perfect.
Dr. Old, we have a question for you about our research.
Okay.
So
Help me remember what y'all are doing.
Well,
are y'all doing it together or
Yes.
different?
So it was
been a
head and
while.
neck cancer, but now it's breast cancer.
Okay.
So,
So y'all are doing the exercise then?
Correct.
Pre-test, post-test.
right.
I'm
And
there.
so, yeah.
Okay.
But so all we're doing is administering a survey because, like, the therapy is technically still it's like standard care. So really, it's just like the survey, and so
Are you going to get them before and after still?
yes,
Okay.
right. But we're not like doing like an intervention.
yeah, we're not doing the intervention. We're just gathering like
Somebody else is, though.
right.
Yes.
But
So it still counts. You would describe that in your methods, whatever that intervention is.
yes, but I think we're doing an exempt IRB though.
That's okay.
Okay.
we're gonna have to do it again.
Yeah. Right. Yeah. Yeah, we're talking about the group exercise, like in like.
Yeah, but in your write-up and stuff, you would still explain what the
Yeah.
protocol was, the program.
Yeah.
Yes,
yeah,
absolutely.
absolutely. So our
So
question-
those names will be blinded. So the 6 or 12 people that fill out the survey, you can't know their names, right?
See, this is what we want to talk to you about.
Okay.
So
Can we walk?
Yes,
I'm
absolutely.
going to go do
Yes.
journal club.
So we're doing our